Welcome to This Explainer. Today, we're unpacking one of the most severe yet thankfully highly treatable conditions in maternal medicine, postpartum psychosis. Look, I know this is an area of medicine that can understandably evoke a lot of fear, but our goal today is to totally demystify it. By looking directly at the clinical data, the treatment protocols, and the prophylactic strategies, we're going to see exactly how medical science responds to this crisis and ultimately protects vulnerable patients. We've got a lot of ground to cover, so let's jump right in.
So, here is our roadmap for today. We'll start with a rare psychiatric emergency, move into acute treatment and safety, explore prophylaxis and relapse prevention, and finish up with medication, breastfeeding, and balance.
Section 1. A rare psychiatric emergency, defining postpartum psychosis. To really understand the scale of this condition, we have to look at the incidence rate. Postpartum psychosis occurs in about 1 to 2 per 1,000 births. Now, clinically speaking, that classifies it as rare. But if you think about a bustling maternity hospital with thousands of deliveries a year, this is a very real, inevitable medical reality that doctors face. Interestingly, most women admitted with this condition actually have zero known psychiatric history, though when a history does exist, it's most frequently tied to bipolar disorder.
So, what is it exactly? The American College of Obstetricians and Gynecologists, or ACOG, has a very specific definition. And notice the language they use here. It is both an obstetric and a psychiatric emergency. It's characterized by an incredibly acute onset, typically striking just 3 to 10 days after birth. We're not talking about a gradual decline over months, it's a sudden, severe onset that frequently arises in the context of bipolar I disorder presenting as a manic, depressive, or even a mixed episode with psychotic features.
When this hits, it represents a massive, dramatic shift from a patient's normal baseline function. You're going to see visual or auditory hallucinations, disorganized thoughts, rapid mood cycling, and just profound agitation. But you know what the most dangerous clinical feature is? Patients typically have limited to no insight into their own condition. They literally don't know they are ill. And because their symptoms can fluctuate wildly throughout the day, prompt recognition by clinicians and family members is absolutely critical. Oh, and before confirming the diagnosis, medical teams have to rule out other physical causes, like thyroid dysfunction, delirium, or the effects of substances.
Section 2. Acute treatment and safety. The immediate rescue.
The stark reality of the acute phase is that because postpartum psychosis carries such devastating, well-documented risks of suicide and infanticide, the safety protocols are completely uncompromising. Psychiatric hospitalization is generally required right away. An emergent psychiatric evaluation is essential to assess the risk of harm, and the patient has to be provided with continuous, one-on-one observation. Under absolutely no circumstances should a patient in the acute phase of this condition be left alone or unattended with their infant.
Okay, so once safety is secured, how do doctors actually treat it? They utilize a very clear sequential acute treatment algorithm. Step 1 relies on short-term benzodiazepines like lorazepam, combined with Step 2, which are sedating antipsychotics like olanzapine or haloperidol. The immediate goal here is simply to rapidly stabilize the severe agitation and psychosis. Once they're stabilized, Step 3 introduces lithium for longer-term maintenance and mood stabilization. Finally, Step 4, electroconvulsive therapy, or ECT, is reserved as a highly effective backup tool if the patient just doesn't respond to the medications.
But here is the most remarkable part of this whole algorithm. 98.4%. In a landmark prospective study of women with first-onset postpartum psychosis, 98.4% of patients achieved remission within just those first 3 medication steps. None of the patients in that cohort even required ECT. This single statistic is huge. It transforms a terrifying medical emergency into a highly treatable condition where the vast majority of patients can return to sustained wellness.
Section 3. Prophylaxis and relapse prevention, the medical shield.
Preventing a relapse relies heavily on high-dose lithium, but the timing of when to start it requires immense clinical precision. And that core distinction depends entirely on the patient's history. For women who have only ever experienced psychosis in the postpartum period, what doctors call isolated postpartum psychosis, the strategy is to initiate lithium immediately after delivery. This brilliantly spares the fetus from any in utero medication exposure while still protecting the mother the second she enters that high-risk postpartum window. However, for women with a broader diagnosis of bipolar disorder, continuous prophylaxis is required throughout the entire pregnancy and postpartum period. Why? Because the risk of relapse during the pregnancy itself is just far too high.
And if you want to know just how effective that medical shield is, check this out. For women with bipolar disorder who remained medication-free during pregnancy, the postpartum relapse rate was a devastating 66%. But for those who maintained their prophylactic medication, that risk plummeted to 23%. This proves that maintaining that medical shield is one of the single most effective interventions we have. But actually administering lithium during the perinatal period, it requires incredibly precise monitoring. Think about it. A mother's physiology, specifically her kidney function, undergoes massive shifts. During pregnancy, renal clearance increases, meaning patients often need higher doses of their medication. But immediately after delivery, the glomerular filtration rate, or GFR, abruptly returns to baseline. This means a dose that was perfectly safe in the third trimester can rapidly become toxic in the days following birth. Care teams have to target a strict blood lithium level between 0.8 and 1.0. Quickly step down to pre-pregnancy doses, and watch out for anything that alters kidney function, like preeclampsia, hemorrhage, or even standard postpartum NSAID painkillers. Because if those lithium levels hit 1.5, you are entering the danger zone of toxicity.
Section 4. Medication, breastfeeding, and balance, the nuance of care.
So what happens when a mother wishes to breastfeed? Clinicians are faced with a very difficult medical trade-off. Lithium is the undisputed gold standard for preventing a relapse. However, its use during lactation is highly controversial because the infant can absorb meaningful levels of the drug through breast milk. On the flip side, second-generation antipsychotics like quetiapine and olanzapine are the preferred options for breastfeeding because very little of the medication reaches the infant. The catch? They have minimal clinical evidence for actually preventing a postpartum relapse. It's this constant tug-of-war between maximum maternal efficacy and maximum infant medication safety.
So how do the guidelines navigate this trade-off? Well, they rely on one single unifying medical principle. If a woman is stable on a given medication through pregnancy, that agent should be continued postpartum rather than switched. Avoiding maternal destabilization is absolutely paramount. You simply do not switch a working medication, like lithium, to an antipsychotic solely for the purpose of lactation, because at the end of the day, a relapse of psychosis is far more dangerous to both the mother and the baby than the carefully monitored transfer of medication.
Now, if a mother and her care team make the shared decision to continue lithium while breastfeeding, strict surveillance is non-negotiable. This isn't something an obstetrician or a psychiatrist can just manage alone. It requires seamless, constant coordination with a pediatrician to regularly monitor the infant's serum lithium levels as well as their thyroid and renal function, just to ensure absolutely no toxicity develops in the baby.
Beyond the medications, we also have to look at environmental triggers. It is vital to remember that sleep disruption is a massive, well-documented trigger for a bipolar or psychotic relapse. This makes sleep preservation a highly potent, non-pharmacologic medical intervention. In practical terms, this often means forgoing overnight breastfeeding so the mother can get continuous, uninterrupted sleep. Having a partner handle night feeds with a bottle isn't just helpful, it is quite literally a lifesaver that stabilizes the mother's brain during this highly vulnerable window.
As we wrap up this explainer, I want to leave you with this provocative thought. When we look at all this data, the algorithms, the strict safety protocols, we realize that navigating postpartum psychosis isn't just about clinical math, it's about deeply personal choices. How do we, as a medical community and as a society, best balance a mother's literal mental survival with her profound desire to breastfeed and bond with her child? It requires nuance, intense support, and a complete absence of judgment. Thank you for joining me to explore this critical topic, and I hope this provided a clear lens into how we protect our most vulnerable mothers.